Okay. Well, hello, everyone. It looks like we are getting about almost 2 minutes after the hour, so I think we have a lot to cover tonight. So I want to make sure that our speakers have all of the time they need to get through everything. So I'm going to go ahead and get started. So hello and welcome and good evening. Thank you for joining us tonight and welcome to our webinar. If you're new here, welcome. If you are a returning attendee, we are very happy to have you back. This study club was founded in early 2024, and the Endodontic Study Club is dedicated to building a strong endodontic community while providing meaningful peer-led CE education on a monthly basis. As a reminder, we meet on the third Wednesday of each month, and we hope to welcome those joining us tonight back for future study club sessions. For this evening's webinar, we have the pleasure of hearing from Dr. Najia Usman and Dr. Alan Law. I would like to, quickly review tonight's webinar objectives. So during tonight's study club, we will be reviewing the findings of the AAE study sponsored by Sonendo to understand the importance of the endodontist referral relationship, which highlights the role of the endodontist as the leader of the oral healthcare team. We're going to describe the latest research that highlights how resolution of endodontic infections can impact systemic health. We're going to understand the endodontist's crucial role in managing traumatic orofacial injuries from the start, as well as managing dental pain. This webinar does include 1.5 CE, so I'm going to really quickly review the CE process. You must be individually registered, attendance will be recorded via Zoom, and an internal CE validation will take place. Make sure your full name, I'm going to say that again, make sure your full name is visible in your Zoom profile. If it's not, just message us in the chat your full name so that way we're able to validate that you were on this webinar. A survey will be sent via email, and then a CE cert will be sent via email after the survey is completed. If you have any questions at all, don't hesitate to reach out to education@Sonendo. And just a reminder, this is an interactive session. Questions are highly encouraged, and there will be a dedicated Q&A session at the end. If you have any questions, please put them in the chat box, and we will review these at the end. And there'll be an opportunity to even come off mute and engage directly with our speakers. And as a reminder as well, just make sure that you remain on mute until the presentation is over. And now it is my pleasure to introduce tonight's study club. As a proud partner and sponsor of Save Your Tooth Month, this evening's topic, the endodontist as quarterback, is especially fitting. Joining us tonight for a unique fireside chat style discussion are Dr. Najia Usman, outgoing chair of the American Association of Endodontists Professional and Public Relations Committee, and Dr. Alan Law, past president of the AAE. Together, they'll explore the evolving role of the modern endodontist in leading interdisciplinary patient care. I'm very excited to hear from both Dr. Law and Dr. Usman.
Thank you so much, Marina. Appreciate you. Thank you very, very much.
Thank you, Marina, and thank you, Najia, for inviting me to be part of this. It's an honor to share the screen with you and to be part of this presentation. You have been involved with the PPRC at the AAE for quite a while. Thank you for your advocacy for our specialty and for your leadership on that group. It's a very hard working group, as you know. That committee, it's one of the hardest working committees in the AAE and one of the most important as it advocates for our specialty and promotes what we can do for patients and for our colleagues in dentistry. Can you explain what the PPRC is?
I'm happy to, Alan, and thank you so much for that question. And I'm going to plug volunteerism in our specialty in general. There are lots of committees and also many different areas where our members can volunteer. And it's one of those things, I'm sure you can agree, that I think you get more from these experiences than you probably give and being able to network. But specifically, the PPRC is the acronym for the Public and Professional Relations Committee. And while you're right, we probably do quite a bit of work. It's a lot of fun, creative work. And so, maybe you may remember in your career, I certainly remember earlier in my career that when I became an endodontist, we used to talk about a busyness problem, meaning this was 2002, and I was noticing that a lot of endodontics, this was, introduction of NiTi files into, by the companies, and a lot of general dentists were taking and doing a lot of endodontics themselves. And so, um, generally speaking, because of the work of the PPRC and because of the increased awareness that they have done through different marketing initiatives, we have sort of changed that trend. So, what I would say, as you mentioned, the Public and the Professional Relations Committee is charged with very tactical marketing initiatives that, if I had to kind of lump it into like a slogan or a saying, I would say that they're charged with making member dentists, member endodontists more successful, and increasing awareness to the public of what endodontists deliver in terms of their expertise.
Thank you. And what specifically was your involvement with the committee?
So, on any of the AA committees, I believe you're allowed 3 terms. So 2 terms I served as a member, 2 2-year terms, and then in my last 2 years, I was chair of that particular committee. And now I'm outgoing consultant, and Lauren Bellis from Pennsylvania. She's now going to be chair. She's sat with me for some time. So as chair, I've gotten to see a lot of evolution with this.
Wonderful. And I was on the committee many years ago. We were working a lot on the patient-facing information that we provide. And what's the committee doing now?
I wanted to kind of tell everyone, you know, how this has all evolved. And so they may have seen on the AA portal, finding your endodontist, in your, to be able to locate one in your area. And it's on the patient-facing side of our website. But generally speaking, it started with this whole worth saving campaign. Hence, us deciding to do this concept lecture today in our May worth saving month, because it started with this initiative of promoting why doing root canals is important. And then the second part of the initiative, initially that the PPRC was focused on, is who are endodontists and why are they the ones that should be charged with saving teeth? Specifically, the PPRC has been responsible. I'm sure many people have seen, if you're on social media, the TikToks, the influencers that are within our specialty, as well as medical professionals, pediatric dentists, pediatricians, that sort of thing. We're also foraying into how AI is influencing decision making, on the web, and how we kind of have, it's not necessarily search engine optimization. I will tell you that the group that under Kim Fitzsimmons is so agile. They're constantly moving and in front of marketing. I'm shocked that just all the things that they touch from. I think we even did in Times Square. We had like a bulletin board there, and so just again, a lot of things. And the survey that we're going to talk about is one of the initiatives that Sonendo collaborated with the PPRC, again, to help member endodontists be more successful.
And for those of you online, if you haven't heard, for the past few years, I know the last 2 years at least, endodontics, if you look at the different specialties, for example, orthodontics and oral surgery, they're actually losing market share, the percentage of procedures that are being done by specialists. And endodontics is gaining market share, meaning a greater percentage of root canal treatments are being done by endodontists. It's all coinciding with your term on this committee, Najia, so I'm going to give you full credit for that, for all the gain we had in market share. I think it's pretty remarkable. You were selected by Sonendo to pick a topic, and you picked endodontics as a quarterback. So why did you pick that topic?
So, it's interesting because I've been there for 6 years and I sort of started with this whole worth saving campaign and in alignment. I kind of, on a personal level, talked about certain things that I felt were really, really important that I wanted to shape decision making with regards to people seeking out endodontists for as experts. And I looked at to be honest with you, I looked at my own practice and I saw a real gap in understanding with regards to trauma. And I thought, to be honest, I discussed it with staff of the PPRC, Kim and Elizabeth, and I said, you know what? I want my legacy to not only be that, endodontists are the people that are experts at worth saving teeth, and they should be sought to save teeth. That was kind of the original message of the PPRC. But I want to go one step further, and I want other health professionals in the public to understand that our knowledge base needs to be sought as almost a resource from the very beginning in directing care. And so a lot of the things we're going to talk about are going to equip our our endodontist community, people in our endodontist community, to feel empowered that they should be able to talk to study clubs and their referral base and kind of say, like, listen, you need to loop me in when you're discussing X, Y, and Z. No longer are we going to be the folks that are going to do prescriptive endodontics because we're told that we're just basically, please do a root canal on tooth number 5 because it's a abutment for X, for this. But it's more so our advice is sought from the very, very beginning in directing care for their patients, both systemically as well as obviously for the oral cavity.
So what specific areas then do you think endodontists should be involved with from the very beginning versus being just the recipient of a referral?
So without a doubt, and again, I'm sure it's happened to many people on the call. I feel like there's a lack of knowledge in how to manage pediatric cases. The whole wait and watch thing needs to disappear. I didn't put resorption in here because I kind of it's again, we already had a meaty lecture pack that put together, but anything related to trauma, anything related to pediatric care. I think now that we're talking about vital pulp therapy, I think to be honest with you, even imminent pulp exposures, because again, we know how the materials work. We know how to use them. We're going to follow our results and failures, certainly in pain management and diagnosis, which I know you're going to enlighten us on. So to be honest with you, I almost feel that if you're a generalist and you have a new patient, I would love beyond trauma for them to say, you know what, I need to loop you in with my endodontist so that they can look at a few things and we can make sure that we have thought of everything with regards to your care, but specifically trauma, pain diagnosis, and pediatric, for sure.
Yeah, huge area where we can be resources for patients directly coming to us, or certainly from referrals from their general dentists. You mentioned earlier about the referral survey, which of course is a natural segue for this topic. Can you describe the survey that you and the PPRC created and that San Endo sponsored?
Yeah, so it's interesting. So this original survey, or it was like this survey, it was done in 2012, and so again, the PPRC thought that it would be a great idea to repeat this concept. So, just in terms of the nuts and bolts of this survey, 919 people responded. I don't know what the breakdown is, but they basically asked general dentists and they asked endodontists the same kind of questions, just to kind of find out, what are their different perceptions regarding this referral relationship? You mentioned, Alan, this whole idea of market share, and I was actually surprised when I reviewed the results of this particular study. But the increase in market share for sure is there, which means that we're doing most of the endo. I actually almost assumed it meant that our marketing was so strong that we were getting a lot of self-referrals from the public. But I wanted to emphasize that 90%, I mean, again, this is across the respondents, but 90% of our endodontic work is actually being referred to us. It's not, and it's 10% self-referred. So the marketing is definitely important, But what actually it's probably doing is solidifying perhaps the patient saying to the general dentist that, you know what, I would like to see an endodontist, which is critical. So they asked all kinds of questions. They asked the same kind of questions to both groups. And they kind of asked things like, why do you refer to why do you refer to an endodontist, or what's important in your referral? What makes you choose a particular endodontist? And then they asked endodontists that, why do you think your referrals, like you, or why did they come to you? So it was things like that. And just an overall answer is that generally speaking, both parties are in alignment. But that was the one thing that I found was very interesting about that study.
Yeah, I think that there's an assumption that if you give them some sort of a referral, it's going to be solidifying referrals, but that the survey didn't show that. There were a lot of other things that General Dentist said were more important than some sort of a gift. It was obviously the reputation and referrals from recommendations from other dentists in the community. So it's important to build that stature and that relationship with the doctors through being a resource, I think, is important. So how do you feel this information can improve our referral relationships with the general dentists?
So I think touch points are important. So like I said, I think that sometimes we may assume that you know how good our endodontics is or how great our white lines are. It's not necessarily that. I think old is gold. And what I found from reviewing this study was that general dentists absolutely value information is king. So they want to, the couple of things. Number one, and I think we all know this, they definitely want their patients to return back to them. So they kind of want that reinforcement. If they are referring to us because there is some implied implied expertise, they kind of almost want that same reverence that, you know what, I'm sending you back to Dr. Jones because they're going to put this particular restoration together, or they know how to manage you this. So that's particularly important. I also think that in terms of how do we access our referrals, like a lot of times people may think like, taking your as endodontists, we should be taking our referrals, out for, games and things like that and forming relationships that way. Believe it or not, sharing information, making it sort of seamless for the patient. So when the patient comes back to the dentist, they like that. And likewise, interestingly enough, patients also want to know that their dentist has communicated with their specialist really well. So they love being able to walk into the office, our office, for example, and know that our x-ray is there. We already know about their treatment plan. We already have gotten the x-rays ahead of time, things like that. So that kind of behind the scenes coordination between offices implies sort of a next level relationship that really solidifies the endodontist and generalist referral relationship. And so I think that how we can use that is to kind of sow those relationships and make sure we know, because you know what, generally speaking, generalists work with only 3 or 4 specialists. So we need to be one of those 3 or 4 people. Once they like somebody, they like them. So we need to do those things.
Yeah. Believe it was James Walcott that published the original survey results. Will this be published in the JOE?
Yes. Kim and I were discussing how do we put this in a format that we can get published. So that's going to be definitely the intent. And we thank Sonendo for supporting this. I think that this was important to kind of hear about this. Maybe this isn't sort of rocket science, but it's nice to know that some of the things that we think or conjecture are backed up by proper scientific methods.
Yeah. One of the things you mentioned earlier was how responsive our marketing team is when questions come up from the public, when myths come up. And one of the things that came up several years ago was root cause the video, and the fact that root canal treatments would cause cancer and other systemic diseases. Interestingly, this question has been approached in a different way recently with the research by Sadia Niazi, and she talks about the relationship between endodontic treatment and systemic health and how it can actually improve your systemic health with root canal treatment. Can you talk a little bit about that body of research? It's got a lot of
Yes.
press, certainly.
Yeah. So this is, I'm super excited about this. And I don't know if anyone saw some of the sound bites we did on our Instagram, but, Sadia and I did a little tete-a-tete talking about her research. So simply put, she kind of evaluated, I believe it was 44 different, let me look and see here. I want to be accurate. Um, she looked at 45 different blood markers, biomarkers, and measured those. And basically, the scientific design was um, you're looking at retreatment specifically, cases with periapical radiolucencies, checking biomarkers, and then basically treating these endodontic cases, grad students, getting healing, and then checking those biomarkers and seeing how it also affected their systemic health. And basically, this research highlighted that integration of how periapical health, endodontic disease can impact body health, and obviously, how if we reduce these lesions, which are very common issues, we can improve systemic health. So they're not, and I asked Sadia specifically this question because, you know, you talked about root cause and focal infection theory, and to some extent has been touted as a means to kind of talk about how endodontics is unsafe. Well, actually, what we're showing with her research is that proper endodontics done at specialty level elicits healing that is commensurate with elevating health, which I think is mind blowing. I think, Perio's been talking about it for years, but when now we actually have objective evidence that we can apply to endodontics. So I love this.
And you mentioned some systemic disease. What specific systemic diseases were impacted by the non-healing lesions?
So diabetes, certainly cardiovascular health. They were looking at lipids in the blood, so the cardiovascular risk. Those specifically were things that she focused on.
And in that article, she talked about inflammatory burden. Can you explain to us and how we can explain to our patients what is inflammatory burden and why is it important?
So simply put, I mean, again, it's fun to speak to other endodontists about this, but basically around a periapical radiolucency, you have the biofilm. The biofilm has basically an inflammatory storm around that area. You have bacteremia, and that's the key here. The bacteremia obviously can not necessarily seed infection elsewhere, but that inflammatory burden that's in the bacteremia essentially supports these other diseases that you can have. So you lower your risk for diabetes and cardiovascular disease by reducing things that reduce, you reduce the bacteremia. Basically, that's the purported mechanism.
And I'm thinking back to when I was hearing the phrase floss or die from the periodontist, reducing the inflammatory burden by reducing plaque around the teeth. How do we message this information from her study to the public? How do you see, does the PPRC have a role in that? Do endodontists?
Yes. Well, so kind of. I think our first sort of method to get this information out is number one. I think obviously, this research is like getting a lot of traction even from the World Health Organization. So I think threefold. Number one, we absolutely want, this is the purpose of this particular talk today. We want to be able to tell our referrals that, why endodontic health is important and why we need to not just watch, periapical radiolucencies, because this is affecting their systemic health as well. So that's critical. We need our physician colleagues to understand why we need to be looped in when we're talking about, again, managing a patient's health overall. And from a policy standpoint, one of the things I think Sadia is on a mission for, Dr. Niazi, is to kind of take this disease. Periapical radiolucencies are the third most prevalent disease. I didn't know. She informed me. And so oral disease. And so therefore, we need to explain that something that can so be simply managed, allow patients to keep their teeth with proficient root canals, can also be involved in promoting their overall health. And so we need some sort of investment in terms of information. So I think so the PPRC will likely continue this type of messaging. I think that it's one of those things that it's going to be a multi-layered approach. And I think using our influencers, certainly doing press releases, all the tools that they use, they're going to make sure that this information becomes commonplace now. Just like perio, we all know that, or at least every lay person knows, like you said, if they don't floss, they could have a low birth weight baby. How did we come to know this information? Because we've been hit with it over the past 20 years, over and over and over again.
Yeah. And obviously it's a strong correlation between the apical pathosis and the systemic diseases. What are the future areas of this research that are going to be important to push us along and to solidify the relationship?
You know what? I mean, that's a good question. I think that they're going to have to do more controlled studies where they actually show over time the actual reduction of disease. I think that that's always something that, and again, I'm speaking from conjecture. That's not something that I know specifically from Sadia. I'm absolutely going to ask her that question. You caught me off guard, Alan. But I think that that's a logical thing is that to me, if I'm thinking about scientific design, I would want to actually do some type of manipulation and sort of see treatment over time and how it may be affected by even coronal restorations and, pre-existing conditions. Can we reverse disease to a great extent? Who are people that are more, susceptible? Are there times when you sort of need to not be so heroic with teeth? Like, for example, for a long time, we've accepted the fact that patients that are undergoing head and neck radiation for squamous cell carcinoma, for example, we have to be a little bit more vigilant because those patients are at risk for, osteoradionecrosis afterwards. So I think that would be, to me, a focus of where do we draw the line in terms of what teeth we try to save or are good risks for doing endodontic treatment with regards to their systemic health. But I don't know, do you have an opinion on that?
Well, I think finding causal mechanisms, so changing something to see if it's necessary and sufficient to cause the change is going to be important. So looking at mechanisms, whether it's in animal models, certainly looking at big data to see if this is borne out in larger scale studies, I think is going to be important. But you've hit on some important points. And it's such an interesting area. I'm glad we're seeing some of this research. For a long time, we were telling people this won't affect you systemically if you have this disease. So it's not urgent to get this done. In some cases, that line of thinking may change. It is changing now as a result of this research. Pediatric trauma, you meant. Go ahead.
No, I just wanted to add that one thing. And I think the one fundamental thing that I hope that the naysayers don't jump on is that, so you are saying that root canals can cause systemic disease. And therefore, I wanted to highlight, and, for our colleagues that are watching, that no, proper endodontics today, because of the techniques and the techniques, materials that we have, are eliciting results that allow us to have our cake and eat it too, keep our teeth, as well as, improve our systemic health because of what we've talked about here. So sorry.
Right. You bring up a really good point, because people who have more root canal treatments and they might have more systemic disease, the root canal treatment is actually a surrogate for the disease. They had a lot of disease before they had the root canal treatment. So if the apical pathosis is causing systemic conditions, that was there before they had the root canal treatment. We may have lessened the burden, the inflammatory burden, et cetera, but they still had that before they had the root canal treatment. So it's important to understand that when we interpret the results.
Exactly right.
Yeah.
Exactly right.
I know we're running on a timeline here, so I want to go to the next topic, which is pediatric trauma. You said endodontists should be taking the lead here. Can you be specific about why and where, in what areas we should be taking the lead?
So this was something that I actually gave a lecture on at the AE this year. And again, I arrogantly made this comment because of stuff that I was seeing in my own practice. Like, for example, common things that we always see when we see like, a tooth that could have had apexogenesis, and it was kind of, a composite was placed on it. And it comes down to people just not knowing what can be done. And so I kind of felt like, number one, it is so critical for us to let our referrals know what kind of things can be done today. I used to think, and I do teach pediatric dental residents how to do simple pulp vitality treatments. And the unfortunate thing is right now, what I'm finding is, again, there's a little bit of misinformation because I feel like pediatric dentists are almost learning in a silo of their own based on the materials, and I don't know what's driving that, but I don't think that they do treatments the way we do treatments. So after sort of trying to teach them how to do these treatments, I'm almost, and I may be standing alone here, but I almost feel like I've come back to this whole point of saying, like, look, there's so much on the line here with an open apex. Please send them to us to diagnose. And the other fundamental reason is because we end up seeing those cases when they're not done correctly, and we have to do regeneration. So that's one reason why in trauma that I feel we need to be the quarterbacks and we need to be looped in early, because in general, I find a lot of mismanagement of these cases that had we been looped in from go, that means after the traumatic event, after the ER visit, after splinting, I think that the outcomes would be far superior.
Yeah, for the last 10 years, I've taught regenerative endodontics and vital pulp therapy to the pediatric dental residents at the University of Minnesota. And obviously they graduated, they're in the community, many of them. None of them are doing these procedures. They're referring them to us. Now, I think you mentioned an important point that when they're seeing these patients in their residencies, they're seeing them in a hospital setting. They're not going to have the microscopes we're going to have. They're not going to have all the materials necessarily that we have that are so important. They do have MTA. They don't have some of the bioceramics, at least at the University of Minnesota. So I think that is a challenge. And if they don't have the proper setting and the proper instruments, materials, they may not have the success. And then they think that this doesn't work. And then we're doing things like regenerative treatment on the pulpus necrotic, and there's an open apex. So there is a role for us in educating those pediatric dentists, but also getting them to send those patients to us. But that also means we need to know how to manage these patients, the behavioral therapy that we need to be doing to get them comfortable seeing us in the chair, because that's a real challenge. And I think a lot of endodontists don't have the skill set. I'll be honest, we don't see a lot of these patients during our residency, see these patients. So we can do more at the level of the AAE at our annual meeting, getting endodontists more comfortable seeing patients, younger patients. And then also training some pediatric dentists to do that.
No, I that's kind of my mission, and I don't know whether it's just my style. I am a mom myself, and I feel like 50% of my patients are kids, and now I've kind of cultivated this kind of practice where I get trauma referrals from 2 hours away, because you're right, it's a sophisticated procedure, not necessarily for us, but it is intimidating. And then if you have the other sort of confounding fact of managing patients' behavior, for a busy endodontist, it can be something that can be a little challenging. And so I really think my mission is, and so I not only, like you, Alan, I teach pediatric dentists, dental residents, but I also have been recently teaching general dental residents how to do vital pulp therapy, and I'm teaching them to do it the right way. I compare it like you're not buttering a pulp horn with a bioceramic. You are literally putting a deliberate interface there that is sealing and creating an opportunity for odontoblasts to kind of grow there and create a dental bridge for predictability. And you know what? Like, I mean, I think it may be your research, because I've quoted your article in one of my studies, but you know, these types of procedures done properly are more than 95% successful. And so part of it is diagnosis and part of it is execution. So hence the idea of the quarterback. The other reason that I say quarterback is because there are a lot of innovative procedures that again I'm doing, and I'm spreading the word that are managed by the endodontist with the interdisciplinary team, like ridge preservation. When we see teeth that are ankylosed, how do we manage those conditions and submerge the roots and facilitate that next process for the implant, or auto transplantation and building that team with the orthodontist and the oral surgeon, and or orthodontic extrusion with the orthodontist, et cetera, et cetera. So there's multiple things that the well-versed endodontist, even if you don't like doing it, you should know that they can be done, and you should be able to build that team in your community and get these next level procedures done, rather than the way we used to think years ago, that we just sort of extract a tooth, build bone when we need it, and do an implant. We can do so much better than that. So that's
Yeah.
my sort of like die on the sword kind of philosophy.
So can you talk a little bit more about how you assemble your interdisciplinary team? I think endodontists don't always think about that, the fact that we're really in many cases working in silos, and it's how do you break through that for the best interest of the patient?
So, I think again, I have personally, I feel like all of us should know, like like we should have somebody from every single discipline that likes to do these things. And we need to kind of talk to them. I don't know if in your communities, if you have spear study clubs or things like that, but they often discuss some of these sophisticated procedures that build these teams already. I know in my community, I have a dental anesthesiologist. I have like a orthodontist. My husband's an oral maxillofacial surgeon, things like that. So I think you need to have somebody. On the other hand, I have spoken to an orthodontist across town because of patients' geography they didn't want to work with my orthodontist. And I picked up the phone and I said, hey, you know what, would you be open to us doing, a, you know, uh, like a ridge preservation by a decoronation? And he was like, you know what, I just do bread and butter orthodontics. I don't want to have to babysit like this gap for like 8 years on this male child. And I said, you know what, bygones, no problem. But then I communicated with the parent and I said, listen, this is what can be done these days. These are cases that that we've done. And if you'd love to do it, this is what I can offer you. And to be honest with you, this is part of informed consent because, I don't know if you recall, but years ago, they used to say that if you didn't offer your patient an implant and if you only offered them a bridge, you were alive. You don't have to do the implant, but you need to let patients know what can be done in the marketplace. And that's
Right.
again what one of the missions of this particular lecture is to kind of like tell you how to sort of do it. Even if you don't want to do it, you should know how to have those conversations and kind of have those things in place so that if you do an orthodontic extrusion and you have to do a gingivectomy, you should have a periodontist that's consulted with these parents ahead of time so they kind of know what they're going to do. So I guess, simply put, you need to build a team ahead of time. You can't build it on the fly. And patients need to be informed so that they can meet those people, or even in today's day and age, get on a Zoom call. I also equip my patients with studies. Like I'll say, look at, here's a study that shows how this procedure is, just to make sure that you know what we're doing. Another big part of the interdisciplinary method of managing these cases with some of these more eccentric type of treatment plans is I let patients know what is our backdoor plan. What are we going to do if it fails? We are hoping for this outcome. I don't have any research to support prognosis because these are rare things. But in the event that we don't get the outcome that we want, we're going to slide into this particular thing. So again, as an endodontist, I feel because I'm the first in line, hopefully for these trauma cases, I can kind of direct care and tell them all the specialists that will be involved, the timeline, what will happen if things go south, et cetera, et cetera.
It's interesting. And 28 years ago, I started a multi-specialty practice in Twin Cities by working with a periodontist. And so there were the two of us, and now there are almost 50 specialists in our practice. And I work alongside oral surgeons and periodontists. And what I discovered is when they know what we can do, they're much less likely to recommend extraction. In fact, they'll say, try to hang on to this tooth as long as possible because they know implants aren't forever. And they'll work with me to save a tooth with resorption before they recommend taking a tooth out. So I think there's a role, as you talk about us as being a quarterback, that's an example of where I think we are the quarterback. They're coming to us and saying, what should be done with this tooth? So the greater you can the earlier you can develop those relationships, I think the better off you're going to be, because you'll be busier as an endodontist, but also the patients are going to be better served because they're going to be getting treatment that's most appropriate and retaining their teeth if possible.
100%, 100%. No, I 100% agree with you. So, I mean, I think it's been fun, and it's I think allowed my practice and to be creative as well. And I think it's, again, when you define yourself as somebody who really, holds the banner of saving teeth, and you're going to do this and you're going to direct, automatically your community is going to see you as that person. So I do feel like there is a shift that not only comes from marketing, but more and more endodontists are sought for their advice, as you've mentioned. And maybe these large group practices that have, multi-specialty practices is helping that as well, because I think one of the barriers to interdisciplinary care is this idea of, having to go to physical, make an appointment here, make an appointment there. In my practice, and it's just my luck of where I practice in Ohio, my husband's right there. My orthodontist is in the same medical plaza. The pediatric dentist is downstairs. So patients really, in one day's visit, we can get a lot done, and they feel a lot of relief, because, I mean, nobody has time these days, and they want to get as much done as possible. And I'll tell you what, and you may have noticed this too, Alan, you'd be surprised how much patients will be very particular about what they'll spend for themselves, but when it comes to their kids, they will seek out the best treatment to save the natural tooth. It is amazing what patients will see. And even if it's a kind of a pie in the sky, like, I think this will work. I've had mobile teeth kicked out by a horse, and patients will travel from 3 hours away just for me to do a checkup.
Yeah.
Yeah. So.
That's when you're seen as a resource. You and I were talking yesterday about this webinar, and it made me think about a recent study that I just presented at the AAE, because you were talking about endodontists as a resource. I think with the advent of AI, general dentists are assuming they're going to be able to get all the information they need regarding endodontic diagnosis and treatment planning, and even how to do the treatment from AI, ChatGPT, Gemini, and Mahmoud Torbinejad and others. And I did some research, and if you'll indulge me here, I'm going to pull up I'll pull up some of our results, because I think it's interesting, and it proves the point that we need to have endodontists as the experts and not rely on ChatGPT and other sources. So I need to just minimize my screen here. Hang on a second.
Perfect.
Okay. So there's a lot of information on this. What we did was we had over 600 cases, and these were retreatment cases, and we provided ChatGPT and Gemini with radiographs, with all of the health information for the patient. We provided all the pulpal testing and apical testing, but we did not provide ChatGPT and Gemini with the diagnosis. So we asked the ChatGPT and Gemini, what's the diagnosis? And obviously in this particular case, it was previously treated. And then we asked the periapical diagnosis, and I'll tell you what these lines mean on the upper left here in just a moment. We asked them, what's the quality of the restoration? Because that will certainly impact whether you retreat a case if you don't see any radiolucency, but there's likely leakage. Quality of the root canal treatment, was it adequate apical density, etc. Apical length. Separated instrument, was that present? That may determine whether you do non-surgical or surgical retreatment. And then is there a post present? So you can see here 90% accuracy. This is agreeing with 8 experts, that endodontists that were reviewing the cases. And you can see that in most cases, they got ChatGPT did better than Gemini for pulpal diagnosis and periapical diagnosis. but they never got to 100%. They were worse at looking at the radiograph, so they didn't do a good job at looking at the quality of the root canal treatment. It's more like 60 or 70% in these cases. Whether a post was present, they were less likely to find a post radiographically. And then treatment plan, whether this should be retreated surgically or non-surgically. In most cases, they did not do well, and they tended to underestimate the difficulty of the case, which is a real concern with general dentists. We found the exact same thing with our initial treatment cases, which I don't have here. When we entered those over 700 cases into ChatGPT and Gemini, the diagnosis was not always correct, and the case difficulty was underestimated, which might make general practitioners think I can take on this case. So then we looked at all individual endpoints individually. So all these categories, how often was it correct? 80 to 83% of the time. If you looked at the 4 endpoint composite, meaning did they get a pulpal diagnosis, apical diagnosis, treatment plan, and case difficulty, they only got all 4 of those things right less than half the time. And if they had to get all of these things right, Gemini got all of them right 26% of the time, and ChatGPT got them right 18% of the time. And in many cases, they were recommending inappropriate treatment. So we should be seen as the experts with our experience, and practitioners should not be relying on these large language models to arrive at their diagnosis and treatment plan. And this is the exact same thing we saw with initial treatment. And again, I don't have the tables or the figures to show you, but just realize that we're seeing the same thing. And as it relates to the case difficulty assessment, this is another critical area, and this we published in the International Endodontic Journal earlier this year, or maybe it was late last year. Time flies. Case difficulty assessment by general dentists and endodontists, and we found that endodontists in general were seeing more difficult cases, which is not surprising. But even though the general dentists had easier cases, they were having more complications. So these orange bars are showing any complication that occurred during or after the root canal treatment, and you can see that they occurred in 19% of the time for general dentists and 12% of the time for specialists or for endodontists. And specifically, general dentists were more likely to have obturation greater than 2 millimeters from the apex. They were more likely to have obturations beyond the apex. You can see about 50% more likely in these 2 areas. And then they were more likely to separate instruments, meaning 2% of the time it happened with endodontists and 3% of the time with general dentists. So this reinforces a couple things. One is we should be seen as the experts when it comes to diagnosis, treatment planning, and case difficulty assessment. And then if the treatment is provided, we're more likely to get a positive outcome because we're less likely to have a complication, even though we're seeing more difficult cases.
No, and again, it just highlights this value and what we need to communicate to our referral community, as that, the concept of diagnosis and the concept of whether to treat or not to treat can't be just deferred to something as simple as feeding, your chart notes into AI and coming up with a decision to treat or not treat. So again, it just points to how important, how our value is not only in the technical aspect, but also in the decision-making aspect. I wanted to switch gears a little bit, Alan, because I don't know, your focus, your PhD was in the area of pain. So I wanted to start with a big picture. I know that we're should be seen as a quarterback when it comes to research and management of endodontic pain as well, not just in trauma. And so root canals do have a fearsome reputation. What does the research actually say about how well, root canals relieve pain? Can you expand on that, please?
Well, first of all, I'll back up and say this is based upon 15 years of research, practice-based research. So going into the general dentists and endodontist offices, having them collect the data. They consent the patients. They do all the data collection. We sent surveys to the patients. So this is over combined between our first study that was done in the late 2010s and then or 2000 early before 2010. The second study was done in late 2010s. Over 2,500 patients we followed across the country. So this is a lot of data done in dental offices, so outside of an academic setting where it's real life endodontics being done. So that's the first point I want to make is that this is what we're seeing as in patients that are being seen out in private practice. And what we found, and this was a paper we published in 2014, is that if you look at measures like are you able to function with the tooth, there's a significant improvement in the treatment. That just should not surprise us. We're very good technically at removing the source of inflammation and infection from the pulp space. But there is a meaningful minority, meaning 1 in 5 to 1 in 7 patients do report severe pain at some point in time in the week after the treatment. So 14 to 19% of patients report severe pain, meaning a pain level of 7 or greater out of 10 in that week. What's interesting is that in a lot of the research, we don't see that. We hear flare-up rates of being around 3 to maybe 8%. But when the patient doesn't have to call their endodontist or their general dentist, all they have to do is send in a survey that marks their worst pain in the past week. They're saying 14 to 7 to 19% of the time, I'm having severe pain. So that's what we became interested in. Can we predict who's going to have that severe pain, and then can that lead us into interventions that will be effective in preventing or managing that pain?
So can you tell which patients, can you predict which patients will have that kind of pain?
Our first study that we published in 2015 showed 3 major factors, and one was, not surprisingly, the severity of pain that the patient presents with. So patients that come in with more severe pain are more likely to report severe pain in a week after treatment. And we also found that the level of optimism about treatment was protective, meaning the more optimistic the patient was about the treatment, the less likely they were to have pain. So, and I'll back up and say that Ali Nasrat and others and I looked at the history of pain research, and we saw that 10, 20 years ago, it was all about what techniques are we doing that can impact post-treatment pain. But nothing was ever looked at in the way of psychosocial factors and genetic factors, et cetera. Now we're seeing more and more that psychosocial factors like optimism, catastrophizing about treatment, which is the idea that patients will say, this is going to hurt and I'm not going to be able to go to work. I'm not going to be able to eat. So they imagine all these things that are going to be resulting from their pain. These patients tend to do worse following dental treatment and root canal treatment. And that's true in medical literature too. So measuring these things is going to be important. In our more recent study, and if you'll indulge me, I'm going to pull up one more graph here because it illustrates the point with, it shows what we're measuring, but it also demonstrates our findings. So this is our study that was just published this year. And if I can pull it up here, let me know if you can see it. Is that showing up?
Yep.
Okay.
Perfect.
So this was just published in the Journal of Dentistry, and it looks at several factors. First of all, we looked at everything that you could possibly imagine, whether there was nickel titanium instruments used, did they use Gates Gliddens, any type of sealer, obturation technique, lots of demographic information, a lot of psychosocial factors. And we use this, it's called a general estimating, or GEE, general estimating equation, that takes everything into account. And when you take everything into account, what rises to the top as predictors for post-treatment pain in the week after treatment. And you can see highlighted in the yellow, female patients, if you go over to the odds ratio here in the final model we used, they were 50% more likely than males to have severe pain in the week after treatment. Statistically significant. If they had severe pain at the time of root canal treatment, so again, a common finding in the literature, they were 50% more likely to have severe pain. If they screened positive for TMD, and we used a 7-question screener that asked what made your pain worse? Opening your mouth wide, chewing on something hard, different jaw movements, and then how often did you have the pain? If they answered 3 out of the 7 questions with a yes, they were screened positive for TMD. These patients were 77% more likely than those without positive TMD screen to have severe pain after treatment. This should not be surprising to anyone. If they had a diagnosis of fibromyalgia, they are over 2 times more likely to have severe pain in the week after treatment. Also should not be surprising if draining sinus tract was protective. And that makes sense because there's no buildup of pressure. The tissue is obviously necrotic. Here's an interesting finding. The use of magnification of 5 or greater was also protected, meaning they were 30% less likely to have severe pain than if a magnification of less than 5 or no magnification was used. And that was an interesting finding also. It's stratified, meaning every level of magnification that was used, because we asked about different levels, was more protective. So that suggests if we're better at removing the tissue from the canal, whether it's necrotic or vital tissue, we're going to have a better result in that first week after treatment. And by the way, we're now just analyzing the data for 6-month pain and pain at 1 year. So we'll see if these same factors contribute to pain, persistent pain, and not just acute pain.
Well, you know what's interesting about that, and you and I were touching on it before the lecture, but this idea of the magnification, what I didn't, you talked about this whole optimism thing. I think the psychosomatic or the psychological impression and how it influences pain is critical. What do you think of my suggestion here that I think use of magnification or technology can affect that psychological perception or skew the perception of, I'm going to feel better or I am feeling better. And also the interpretation of pain is healing pain versus traumatic pain versus pathological pain. You know what I mean? I do feel like that comment that you've made about optimism is a huge one that, I didn't realize, because I got to tell you this fun anecdotal story that, how we know that the post-operative flare-up result, at least I remember it from classic lit as being 5%, right? 5% of the time they're going to have a post-operative flare-up. Well, there was an endodontist mentor who, when a patient would call and say, you know what, I'm having this, level 10 pain afterwards, the endodontist would reply, well, this is excellent. Your body is doing exactly what it should be doing. It's the hurricane that blows the trash away. And so framing for our patients what they should be feeling, when they should be feeling it, I think that is the heavy lifting of your research here, because that will affect that whole optimism cycle that will influence their interpretation of their persistent pain as well. It's almost like when I have that, once in a while patient that is still having pain at 4 months or 3-month recall, I will say, listen, our studies show that there's a small percentage of patients that for 6 months they'll have pain. Please be patient. You may be that person. And so
Right.
that expertise, that being able to back it up with data, again, affects that whole optimism. I don't know if you have an opinion on that or, how you
Well,
frame things.
it's interesting. What do we do before we do the treatment? Informed consent. And what does the informed consent do? It says everything that can go wrong, even though it's a low likelihood. So we're creating in some patients this lower level of optimism about the treatment. It's important to frame that though by saying, I'm going to be doing it. First of all, these things don't happen very often. And we're going to be doing everything we can to prevent these things from happening. The other thing about what I just showed you is the fact that females are more likely, patients with TMD are more likely to have severe pain. Identifying that can also help us start to tailor our strategies, and we can talk about those with the patient. So, for example, you have TMD pain. So what are we going to do to manage that so that you're as comfortable as possible during treatment and after treatment? They're seeing you as someone who's caring and trying to help them, and I think that will result in increasing their level of optimism. There are studies with patients at Cleveland Clinic and other areas that are undergoing orthopedic surgery, they will actually do interventions to address catastrophizing and optimism before they ever go in for
Interesting.
treatment. And they're showing that this will improve not just pain after the treatment, but the healing process, their ability to get flexibility in the joint, etc. So I think we have underestimated the importance of some of these psychosocial components and contributing factors for postoperative healing and pain. We're seeing the exact same thing with persistent pain from our previous research that catastrophizing was related to a persistent pain. So the question is, what do we do in the way of interventions?
I love the fact that you've introduced me to a new word, catastrophizing. I'm going to be using that with my kids when they're bothering me. Stop catastrophizing.
A quick anecdote on that, and I apologize if someone heard me say this at the AAE meeting, but my wife went in, she had bunions on both her feet, and she, on the day of surgery, said she got them both done the same day. If somebody does surgery for the Vikings, gets great results. But she said, if this doesn't go well, I'm not going to be able to walk the dog. I'm not going to be able to do all the things I love doing. And I said, honey, people who catastrophize before their appointments tend to have poorer outcomes. It was the worst pep talk I could have given to her. She was so mad leaving the house, and I had to kind of talk her down from this. Like, I was just trying to help. So you have to use that catastrophizing carefully when you're having conversations with people, particularly with
not to your spouse, not to your spouse. Okay, I got it. I got it. Well, you know what? Let's talk about acute management. Tell me what's new in pharmacology for post-procedure pain in acute situations, please.
Well, some of the information should not be surprising, and I'll say it's new only because I was on a group of about 15 to 20 individuals. We worked with the ADA Science Division and then University of Pittsburgh, University of Pennsylvania, and looked at all the literature related to post-treatment pain to develop guidelines. And this was published last year in the Journal of the American Dental Association. And not surprisingly, the most effective medications are anti-inflammatories alone or in combination with Tylenol. And specifically, we found that 400 milligrams of ibuprofen and 500 milligrams of Tylenol was very effective for most patients for their pain, or 440 milligrams of naproxen sodium. So that combination works really well. If not, then we'll be looking at hydrocodone for patients who have breakthrough pain. But one of the newer medications on the scene, and this is something that Don Nixdorf and I are going to be looking at and potentially doing a clinical study, is suzetrigine. So if you're not familiar with suzetrigine, or Genavix is the brand name of it, it's specifically targets a voltage-gated sodium channel and on pain fibers. So it's a non-opioid, and it blocks the perception of pain. And they discovered this because there are certain patients or people that don't experience pain, and they found that this particular channel on their pain fibers was defective. So they said, what if we just block that channel? Will we have better results with pain management? So this is a non-opioid, and it's not an anti-inflammatory. It's just blocking pain signals. So you would use this in addition to ibuprofen. And not only is this being used for acute pain, but also chronic pain. And the main body of literature on this has been with bunionectomies, which is now, I understand, replacing third molars extractions as a good model for pain management. So I think we'll be seeing more of this in the future, suzetrigine. And then I'll just mention for chronic pain or persistent pain, some of the research, the case study that came out of San Antonio with 4 patients showed that gabapentin can be very effective for patients who have pain that's not endodontic in origin. So you've ruled out any organic cause for the pain. This can be very effective, and I'll refer everyone to the article by Hannah Hargreaves was on there, and Nikki Ruparel and others. I can't remember the name of the first author, but it's a gabapentin pyramid where you ramp up the dose of gabapentin over a few days. You keep the patient at that level. When the pain subsides, then you ramp them off the gabapentin. So it's not they're not going to be using this for long periods of time. It's typically a 2 to 3 week period of time they're using the gabapentin. And it's very effective for pain that's likely neuropathic. And our research is showing that roughly maybe 1 to 2% of patients have neuropathic pain following endodontic treatment.
What's the mechanism of neuropathic pain versus inflammatory pain? Like is it like a neuroma basically that's created from apical instrumentation trauma?
Well, we're doing a root amputation, so it's likely it could be related to the nerve trauma. It could also be related to what happened before the root canal treatment. So you have inflammation, and there could be patients that are more susceptible to developing this neuropathic type pain. Neuropathic, we're in the process of recategorizing a lot of pain. So nociceptive pain is associated with inflammation. Neuropathic pain is associated with nerve damage. And then there's something called nociplastic pain, which is more probably centrally mediated, but could also be related to something that happened in the periphery. So the more we know about the mechanisms, the more likely we'll know how to manage these with either suzetrigine, genetics, or gabapentin.
So let's talk about for a minute about preemptive analgesia. Like do you feel like first of all, what do you do and when do you do it? Is it a routine thing? Like, are there certain patients that you'll give ibuprofen out of the gate before you start treatment? What are your strategies?
Yeah, I think first of all, you need to look at how are we tailoring that to the patient. So I think preemptive analgesia, we often think about that as being pharmacologic, but as I mentioned in our findings from our acute pain study, patients who had TMD were much more likely to have severe pain a week after treatment. So if a patient has asymptomatic apical periodontitis and they have acute TMD pain, we should be managing that pain before and trying to eliminate that pain, or at least ameliorate it before we do any endodontic treatment. So looking at non-pharmacologic means, and there also may be some pharmacologic management of their TMD type pain, but minimizing that type of pain, also looking at if patients have neuropathic type pain in addition to their endodontic pain, how do we manage that? So working with their oral facial pain practitioner or their neurologist. And then there are studies that look at using Neurontin prior to surgical procedures and other procedures to minimize post-treatment pain, particularly in patients who have a history of having a lot of pain after procedures. But I'm hoping that what we'll get to in our research is identifying with a 2-minute questionnaire, patients can fill in who's more likely to have pain. So if you're female, if you catastrophize, if you have TMD, if you have a history of fibromyalgia, we could identify you as being 70% more likely than other individuals to have severe pain. We're more likely to use some sort of a preemptive strategy with these patients than we are with someone who doesn't have any of those, doesn't check any of those boxes, where they may not need anything. And then we're going to be considering anti-inflammatories preemptively, using long-acting anesthetic to prevent that nociceptive barrage that can be associated with central sensitization. We may be throwing all these things at the patient, Neurontin, but only for patients that need those types of interventions in preemptive analgesia.
I think pain management, and I love what you're talking about, it has to be elegant, which starts with specific diagnosis for that patient, and then essentially looking at all of the different mechanisms from, like you'd said, right at the tooth to central sensitization, and not just basically throwing everything you can at the patient after the fact. Steroids obviously used to be a tool of the past. And I wanted to ask you that specific question. How often are you prescribing prednisone dose pack and either before treatment or after treatment? And are you using different meds in your diagnosis of pain before you even treat the patient? Like you'd mentioned, using Neurontin beforehand, to kind of, I don't know if you're doing it to rule out or just to essentially remove that contribution of neuropathic pain.
I'm only using a steroid if the patient can't tolerate anti-inflammatory, because I think it's important we stick with the simple relatively simple medications. So I'm more likely to give ibuprofen, or if they do better with Aleve or some medication. I'll ask them what works best for them, and then I'll use that alone or in combination with Tylenol. If that combination isn't working, then I will go to steroid. And I typically now have been using dexamethasone rather than the Medrol dose pack, because dose pack seems to be more disruptive to the sleep, mainly because that first day they're taking it throughout the day, so they're getting more steroid in the evening. As you know, we have this circadian rhythm for our steroids where we tend to have more, our body's producing more steroids in the morning, makes us feel more alert. If you are supplementing that in the evening, they're not going to sleep as well. So the nice thing about the dexamethasone is that it's a morning dose, and then they don't have to take anything in the evening. So I prescribe 4 milligram tablets. They take 2 the first day. If they're still having pain, they'll take 2 the second day, and that's typically all they need, versus the Medrol dose pack, which is 5-day course.
Very good. No, I can never hear enough about pain protocols, because I do think that they change, and I do think that we can become better. And I do think, because it's become a national crisis, the opioid epidemic, that we have to do better with diagnosis, and being more targeted in the way we give drugs. Looking ahead, where do you think the field needs to go from your assessment?
Well, a couple areas that I think are important. I think we need to get more. We need to refine our diagnostic tools, and as you know, the diagnostic terms, I should say, the AAE is looking at this. So there'll be more to come on that, because if you don't make a proper diagnosis, you can't properly manage the patient. I think we also need to look at getting better as endodontists at identifying non-endodontic causes for pain. For example, the patient's still having pain at 6 months, and we can't identify, the tooth is not tentative percussion, we don't identify any apical pathosis, not tentative palpation. We should not be redoing the root canal treatment, because this may be a neuropathy case, or it might be referred TMD pain. So getting better at identifying non-odontogenic causes for pain. And I'll refer everyone to an article that Maria Pig and Don and I wrote on the International Classification for Orofacial Pain. It was published in the Journal of Endodontics a few years ago, that talks about the most common non-odontogenic causes for pain. And you should be familiar with those. And the most common muscle that refers to teeth is the masseter. So being comfortable just palpating the masseter and determining if that's causing the patient's pain is going to be important. The other area I think is going to be important is imaging. And at the University of Minnesota, we have the only dental dedicated MRI machine. There are only about 3 or 4 in the world. One of them is at the University of Minnesota. And we're looking at the signals that are produced by non-healing radiolucencies versus healing radiolucencies. And what we're seeing is that within months after root canal treatment, you can see the signal. It's this white area where there's inflammation. You can see that signal decreasing. So we know that area is healing. Why is that important? Because if the patient is still having pain, but we're not seeing inflammation, we know the pain is very likely non-odontogenic. So we're going to be managing that differently. We don't have that level of certainty when we're doing CBCTs, because all we're seeing is a radiolucency, or in some cases, we're not seeing a radiolucency. And the MRI researchers are also showing, before we see radiolucencies, we're starting to see these signals of inflammation below teeth, and even in the bone 2 or 3 teeth in front and behind the tooth that has the endodontic pathosis, we're seeing the signal of inflammation. So it's really interesting to see what we haven't been able to see before as it relates to the level of involvement in the bone and how we can assess healing after treatment with MRI. The other area that I think is important with MRI is diagnosis of vertical root fraction and cracks in teeth, because you need a certain width of fracture before it shows up on CBCTs. And often, as you know, we don't see the fracture directly. We see the bone loss associated with the fracture in the CBCT. But with MRI, if there's any fluid in that crack, which there likely will be in the tooth and bone, that that area of fluid will light up on an MRI. So it might be
Mm.
much more sensitive than the CBCTs in identifying vertical root fracture cracks of teeth.
I was really excited to hear about this, about the MRI. I think that that's amazing. That again, very forward thinking. And I think like, to know that this kind of technology can be implemented to solve some of the dilemmas that even plague us as experts with inflammation and pain is pretty amazing. I wonder how many years it will take for this to be a kind of a mainstream thing. But I really appreciate, Alan, you spending the time with me this evening. I wanted to do a format that was kind of informal. My intention was this fireside chat concept was to basically take these topics that are lesser known topics and really empower our community um, to kind of show that we really should take a leadership role, not only in oral health, but systemic health as well, and all of the kind of cool things that are going on, whether it's trauma or materials or diagnostics or pain, et cetera, and how we can use that to kind of communicate to our referrals as well. But that to me was a take-home message of tonight. I wanted to know if you had a take-home message for our before we actually entertain the few questions that we have in the chat. Do you have like out of our conversation, do you have an overarching message for our group here?
I think, and it's been thinking about this during our conversation, that what we can offer the general dentist in the community is our knowledge, whether it's for diagnosis, whether it's treatment. And I think we undersell, we often focus on the technique and not what we offer in the way of knowledge and meaning, are we diagnosing whether it's non-odontogenic pain or odontogenic pain? Are we getting a proper treatment plan? Are we assessing the difficulty so that we can determine, is this an appropriate treatment for the patient and who should be doing the treatment? And then, of course, developing those relationships with other specialists in the community is going to be important for us as endodontists if we're going to maximize the benefit for the patient for the care we're providing.
I absolutely agree. Well, I'm going to turn it over to our moderator, Marina. Marina, do you want to give, I mean, Alan and I can both answer the question, or he and I can alternate, or if there's questions that are directed to each, the individual, we can answer them.
Absolutely. Well, first off, just thank you so much. That was very, very interesting. You guys did such a great job of getting through so much information in such a short period of time. So I just appreciate you both. I'm going to start off with what I'm seeing here in the chat. So one comment kind of question as well is, just an encouragement of, I think, the way that AAE is trying to educate the public, it's hitting the nail on the head. We really need to educate our physicians in the community. They get so little, education on this in their schooling. So I guess to turn that into a question, Naja, what are you doing to, kind of connect and educate not only fellow dental colleagues, but medical colleagues in your community?
So I can actually answer that question. We just recently did a partnership with the Urgent Care Physicians of America. They're actually an association, and that collab, if you will sort of get the word out. Specifically, related to dental trauma. Reviewing protocols. I feel like we have like literature that's been passed to them, emergency room physicians as well, that kind of not only highlight what they need to do, but how their next step needs to be, not to call their dentist, but to call the endodontist specifically. So that collaboration has been done or is being done.
Wonderful. Thank you, Dr. Usman. This one's for you, Dr. Law. I know we get people from here in the States, and then we have individuals on from Canada and sometimes even and elsewhere. So we have a question. Is education standardized across schools in the US at both undergrad and post-grad levels?
There's certainly a level of standardization because for CODA, there's a certain level of, and there are different levels of whether it's you're familiar or competent or all the different classifications in different areas. The question is how much education is provided on a specific topic. For example, with non-odontogenic pain, is that going to be just a lecture, or are they actually seeing patients where they're diagnosing these things? Are they working with an orofacial pain specialist? So there is a level of standardization, but within the standardization, it provides the lane lines, but you can move a lot within those lane lines and still meet the requirements for being an accredited program as for general dentists or for specialists. So it's a broad, that might be considered a non-answer, but you have to meet certain standards to be accredited as for dental education in general and then specialty education.
Thank you, Dr. Law. This question is for the both of you, as I would love to hear both of your guys' opinions on this. A question came through. What's your opinion on retreating small asymptomatic apical lesions?
You know, my opinion on this may change because as I talked about with MRI imaging, we may see that some of these small lesions don't have a signal indicating there's inflammation. And in some cases, there may be no lesion. We might see a signal indicating there's inflammation. So I think with improved imaging, that question will be more easily answered. The question is the timeline. When will we get these types of imaging, this type of imaging in our practices?
So I'm going to answer as a clinician, and then I'm going to pretend that I'm Dr. Niazi as well, because we talked about the impact of apical inflammation on systemic health. So for me personally, right now, my decision to treat a case, and I'm going to assume a small lesion is just that. I often do my diagnostic testing, and if there's no clinical evidence, that means palpation over the bone. And now even taking a CBCT, of course, then I'm less likely to treat something small in the moment if I'm just being asked, especially if there's already a crown on the tooth. So the restorative treatment plan impacts my decision as well, to be a little bit preemptive. I'm going to now answer the question from Sadia's perspective. If we are presuming, and if her future research is going to tie biomarkers and its impact on systemic health, my guess is she is going to use biomarkers as an indicator to treat or not treat lesions. And I guess I'm just conjecturing that would be her answer, because she's seeing periapical radiolucencies as a threat to systemic health or systemic well-being or inflammatory burden, et cetera. So
yeah, I think that's a great point. The question is, are the biomarkers indicating that particular tooth is the source biomarkers,
correct,
or is there something else
correct,
going on in the body? So
correct.
how do we get it specific to that area? And that's going to be the next. That's another area of research that we could potentially be looking at. Is there something that you could measure around that tooth that would suggest that tooth is the source of increased levels of these biomarkers?
Thank you. You may have seen, for everyone at home, you may have seen a couple of messages come through the chat from myself. These are just some links that Dr. Usman shared with me. If you're interested in, this was a short hour-and-a-half study club, but if you wanted to dive a little bit deeper in some of the information that she was referencing, I have linked where you can get that information. I've also linked information on if you wanted to review that AAE survey that we started everything off with. I've read it myself. It's very interesting. If you wanted to know where that is located, again, linked it kind of in the chat. I just, again, wanted to say thank you so much to you both. I think this tonight was so interesting. This is what I love about the study club. We do an array of topics, and this was really unique, and I just appreciate the both of you sharing the information that you did. I'm going to really quickly close tonight by just going over what is up and coming for this study group. So let me just quickly share my screen here. So, If you'd like to join us next month, we are meeting on June 17th. Our topic, we're going to switch gears and we're going to do Beyond the Handpiece. So this is really great for not only everyone who's on here tonight, if you're practice owners, but also for your team members. So this is going to be with Michelle Allen and Krista. I'm gonna say Krista Elks. I'm gonna say her name wrong. But this is a wonderful duo they're out of North Carolina. They're a wonderful office as a dental assistant and office manager, and they're gonna go over how they use their skills in the office from the front all the way in the back end. There will be some touches of gentle wave, maintenance, patient acceptance, dealing with, routine, yeah, like I said, maintenance and whatnot. It's going to be a wonderful presentation for you guys. If you'd like to join us again, or for your team members, to join. Again, June 17th, there's a QR code there if you want to scan that. And then I also just wanted to highlight real quick, beyond the study club, we also do have in-person courses that we put on. We have one happening June 6th in Nashville. We still have a couple of spots, I believe, available for that. So if you're interested in coming to an in-person event, it'll be an all-day 8 CEU event to learn about GentleWave. We'd love to have you there. So again, you can scan the code for more information. And then I just wanted to let you guys know you will be receiving a survey after tonight's lecture. We look forward to your feedback. But as many of you may have already known, we have launched our Flow Logic files. These files are designed around a redefined role of the file, especially when used with GentleWave. I'm very excited about the early feedback we have been receiving, as well as the feedback we received at the recent AAE meeting. On your survey, you'll have a question. If you'd like to have a sample sent to your office, just check the checkbox and we can get that out to you guys. And again, just thank you so much to our speakers tonight. I'm so thankful. You guys were just fantastic. I really appreciate having you both on. And thank you to everyone who attended this evening. And I hope to see you back here next month in June. And for the remainder of the year, we have lots of fun topics headed your way. Thank you.
Thank you.
Thank you.
Thank you so much. Appreciate you all.